Sava and Ayub. Right? Buongiorno tutti and good morning everyone. I'm sorry for the pronunciation, I mean it's not a good one. Anyway, let me thank you, the person, my name is Mike, for the very kind and very compensating invitation. It's a great pleasure for me to be here. As you can see, I'm not a woman, but I am a member of the Women's Dermatological Society in my country. And concerning women as dermatologists, I see you are a very active group, so congratulations. I didn't know that the group was 22 years old, so a lot of work for you. I've seen the journal, so good work and congratulations again. So now we have to move, and let me tell you where I live, where I'm based in my country. The city where I live is Bologna, and this one. And I work at the University of Ferrara. Maybe it is better to tell you that I live between Florence and Venice. It's easier for you. I think all of you know where I'm located in my country. So I'm in the middle, very close to them. And if you have time to spend in our country, I'm sure you may enjoy culture. These two cities are medieval cities, and you may enjoy also kitchen and design and environmental areas. So you are welcome to our country, and please contact me. I can help you. So let me say that I'd like to stand and to address a special thank to my mentor. He's a great man, because maybe someone of you knows him. He's a milestone in our work, and I have to thank a lot him for introducing me to this very interesting topic. He's based in Leeds, he's now retired, but he's a very, very important man. And I'd like to celebrate the 70th year of the acne clinic. He suggested me to go on with the acne clinic. And 2 years ago we began a dedicated clinic on eyelid and super. So, now we'll go straight to the topic. That's a very important one. Advantage distance is a very important topic, not only for dermatologists, but for the medical community and for patients. You know that when we use an antibiotic, bacteria tend to respond. And sometimes they are susceptible, sometimes they are resistant. If they are susceptible, they will die. If they are resistant, they will continue to grow, and the disease will continue to go on. There are different ways to get resistance for a bacteria. Vertical one, the mutation occurs inside the bacteria, or contacts with other bacteria may induce the resistance. And this is very important, because when we treat a patient, an active patient, we want to focus on the acnes. We have to remember that there are other bacteria close to the acnes, and then there could be a transfer of resistance between them. You can imagine that a bacterium looks at the antibiotic as an enemy. So the occurrence of resistance, the production of resistance for him is a way of defense. So it's fully logical for him to induce resistance. So every time we use an antibiotic, we have to expect for the bacteria to produce resistance. So the question is not if resistance will come. The question is how quickly the bacterium will develop resistance, and how many strains of the bacterium will get resistance. All of them, there are some of them, and another question is how long resistance will continue to be evident, because you know that resistance may come, but may also come back. And at the end of the day, the most important part is it clinically relevant? Is it a problem for our patients or other kind of disease? We're going to see. So we have seen that antibiotic resistance is a global problem. diffused all over the world. And just to give you an idea, in our country, 44 adults, 53 children, and 50 old people out of 100 get a course of antibiotic per year. And 15 old people out of 100 get 6 courses of antibiotics per year. It's a big number. And you have to imagine that the GA group is so busy, but we found the time to consider the problem of antibiotic resistance. In the last meeting in June 19th this year, they realized that there is a very impressive increase of resistance claims of some so-called superbacteria, such as EWDS, Klebsiella, and methicillin-resistant Staph aureus. We do not understand really how much is important the problem, because as dermatologists, we do not treat the sort of diseases, but our colleagues, internal medicine, anesthesiologists, and infectologists, they know very well what does it mean. But sometimes the sort of bacteria do not, are not under control with the antibiotics we have in our hands now. So the GA decided to pledge to act strongly against bacterial resistance, and they decided to potency research, and they developed new drugs. You know that we do not have new antibiotics for around 15 years. And they focused on GPs at the very important points in our community, because we have to work on them. They are the major prescribers of antibiotics. And at the end of the day, they consider the problem of antibiotic resistance as a climatic change, so a global threat. But why dermatologists, and in particular so-called archaeologists, are interested in antibiotics? There is Piactis. And Piactis is a bacterium that could be reduced by antibiotics. But we have to remember that antibiotics work also as an anti-inflammatory drugs. It is very difficult to keep separated the two actions. And we also have to remember that Piactis is not the only one. It is a pathogenic evolution of acne. And we also know that some acne lesions become evident in some aerosolicious follicles where there is no Piactis. So it is not the only one. That is very important. So the answer to the question is, why do we use antibiotics in acne? Because they work. We have recently seen that Piactis have been sequenced. The genome has been sequenced. So we knew a lot of new things about Piactis. Just to give you an idea about the importance of the genomic knowledge is that we have seen there are different strains of Piactis. And each one works differently in comparison with the others. And some of them are pro-inflammatory, some of them are not inflammatory. Some are normal commensals, and others are true pathogen bacteria. You see that some of those, type 1A, may induce acne, and subtype 1A again may induce ophthalmic infections. But other types, such as type 1B and type 2, may induce infections, very severe infection from the 3 medical devices in very severe patients. And there are some other strains that tend to become resistant. What is the point? Why is it so important? Because in the future, I think we will be able to know in advance what kind of strain that specific patient will have in their cheeks. So we will be able to decide if to treat strongly against the bacterium or not. Because you will see that the strain is not acne inducer, it is not inducer of disease, we can avoid treatment. Piactis, we have seen may induce inflammation, may induce hyperconification, and may induce hyperseborrhea. So it is very busy bacteria. So we have to take care of them. In terms of antibiotics, we as dermatologists prescribe, in the vast majority of the cases, we prescribe tetracyclines. And in terms of tetracycline as a systemic treatment, we worked together in 2004 in a group of dermatologists interested in antibiotics in Europe, and we finalized this study, and we decided that the most important antibiotics to use, and I mean systemic antibiotics, considering efficacy, safety, resistance, and pharmacokinetic aspects, and also side effects profiles, it was concluded that doxycycline and liracycline were the most appropriate antibiotics to use. You may ask me, why not liracycline? Liracycline is very effective, it's well known, but sometimes you may see very severe, not frequently, but very severe side effects. I used a lot of liracycline in the past, but I had 2 cases, very young people, with pseudotumor cerebri. So I have to say it's not a pleasant meeting with the sort of disease. They were very, very young people, 14 and 17 years old, and both of them went okay, and after 1 month of treatment with diuretics and corticosteroids, no side effects. I mean, neurological side effects occurred, but it was a difficult challenge. That's why I prefer to avoid. We have an alternative, so why not to go to the alternative? As a topical treatment, all of you know that clindamycin and erythromycin are the best ones, but the resistance to erythromycin is growing quite quickly, so it's better to focus on clindamycin. When you use the topical antibiotics, you know that it acts preferentially locally, where you apply the cream. But you have to know that if you put a topical antibiotic on your cheek, you may find the same antibiotic on your back and on your chest. Why? Because you touch them and close. You move yourself, so you may spread the antibiotic in different areas of your body. And in those specific areas, I mean back and chest, if you apply it on the cheek, you may experience the so-called edge effect. Because at that specific point, there will be a reduced concentration of the antibiotic. That's the point where antibiotic resistance may grow up. The systemic absorption of topical antibiotics is not so important. I have never seen in the literature one case of GI problems induced by topical clindamycin. Systemic antibiotics obviously are spread all over the body, and their penetrance depends on the tissue distribution of the antibiotic. So when you have in your front of you an activation, and you decide to treat the patient with an antibiotic, what are you expecting to do? Your target is obviously pediatrics, but you have to remember that probably with the topical and for sure with systemic, you will target also other bacteria such as Staphylococci, nose, throat, Streptococci, same places, and with systemic GI tract bacteria and also urinary tract bacteria. So you want to do less than really you are going to do. We can focus on pediatrics. You know that pediatrics may use acne, but also deep infections. What about acne? We know that the occurrence of antibiotic resistance against capness is a worldwide problem. If we compare 1976 with 2003, with the study in Europe, you see a progressive growth. And we have less data from 2003 on, but we can say that I have news from England. Probably there will be in the near future a new study on antibiotic resistance on about 1,000 patients, and it seems to be that the level of resistance is quite the same as 10 years ago. Maybe we learn how to use antibiotics. And here we see an Egyptian study, maybe the author is over here, and we see a prevalence of 65% of the patients with clindamycin resistance, 48% for erythromycin, and some resistance for some tetracyclines. In other countries, there are different amounts of resistance, but what is impressive to me, look here, the United States, it is not a recent data, but they have around 63% and more than 50% anyway of cases of resistance to tetracyclines. That's a consequence of the use of high dosages and long period of treatment with tetracyclines. So, but what are the factors that may influence the generation of resistant strains of PIs? First of all, we have seen what happened in the USA, long-term antibiotic treatment, usually more than 12 weeks, and the inappropriate use of antibiotics where it is not really needed. No dose of antibiotics under the recommended doses, but with the low dose anyway, the antibacterial activity is still present. The concurrent use of different classes of antibiotics, and it is very important, the low adherence to the treatment of the patients. Consider adherence. More than 50% of the patients do not adhere appropriately to the treatment. It is a worldwide study that demonstrated that. And repeated courses of antibiotics, obviously. But what about acne? It is very well demonstrated that if the patient bears on the skin strains of the acne resistant to an antibiotic, I mean, clindamycin or tetracycline or whatever, and you treat the patient with that sort of antibiotics, the outcome, the clinical outcome is very frequently not really what you want to obtain. So the negative effect of antibiotic resistance on the treatment. But remember, PIs may induce very deep infections. I mean endocarditis, may induce endophthalmitis and peritonitis and so on. But fortunately, if you have a look at the treatment that our colleagues take care of this sort of deep and severe infection, the antibiotic they use, you see that the first choice they use beta-lactam, such as penicillin, because this bacteria is susceptible to that sort of antibiotics, and they do not need the use of tetracyclines. So we are not guilty about the occurrence of this sort of disease. We talk about other bacteria present in the environmental area, and Staphylococci and Streptococci. And so the question is, when you treat your patients with that sort of antibiotics, what is the influence you may obtain in the resident flora of that patients? That's an important question. So, if you have a look at this slide, please not go into the details, I just summarize the concept. You see that in some cases the bacteria are increased, in some cases the bacteria are decreased, in some other cases no change in terms of numbers. So, this is our personal experience. We decided to study together with Heidelberg and Leeds, Germany and England, the prevalence of resistant strains to antibiotics used in acne in Propionibacteria on one hand and other resistant residential bacteria on the skin. Staph aureus, Staphylococci, Quadrivalent negative, and Streptococcus viridis. We studied 102 patients, we had 105 volunteers and 93 contacts. At the end of the day, we have seen that considering erythromycin and clindamycin as a consequence of topical use, effectively there was an increase of resistance of Gaddis, Quadrivalent negative Staphylococci, and Streptococci viridis on oral cavity. And it was related to the use of that sort of antibiotics for acne patients. Another story is related to tetracycline. No influence of tetracyclines being used as systemic therapy in that sort of patients, in that sort of bacteria. So, yes, influence of erythromycin, clindamycin, nothing about tetracyclines. So, at the end of the day, what can we say about that specific point? We can summarize that we may have an influence with our antibiotics on that sort of bacteria, but probably there is no clinical relevance. I have no specific data to support that, but I have no, at the same time, data to say that they are responsible. So at the end of the day, I think we can continue to use the sort of antibiotics, following the rules I address you at the end of the presentation. So now another question. You have a patient, and you think to treat the patient with antibiotics. And the question is, do you think that the sort of patients you have in front of you will run the risk of getting severe systemic bacterial infections? We see what the literature gives us few studies, and one of those, the most important one, is full of viruses. They recognized that there was no difference. They were not able to differentiate between viral infections and bacterial infections. And you know that in that area, 90% of infections are viral in origin. So, according to these studies, I think we can say that we have few data, but apparently we do not induce an increased number of infections or bacterial infection in our patients when we use oral or topical antibiotics. And what about very serious disease? We are not used to face that sort of problems. I mean, bacterial pneumonia, both community acquired and hospital acquired, they are very severe diseases. We tend not to face that sort of problems, but our colleagues that they do. And the question is, the antibiotics these colleagues used to treat the so important diseases, are they the same we use for acne? Answer is no. They do not use tetracycline. So I mean, just in case of resistance acquired by the sort of bacteria is not a problem. Because anyway, the treatment would be different from tetracyclines. It doesn't matter. The bacteria pneumonia is getting resistant to tetracycline, it doesn't matter. His treatment will be different in case of pneumonia. So we are not guilty again. That's a good thing. So, I'd like to conclude my presentation summarizing that when we use antibiotic and we consider piatis, and piatis as an inducer of acne, we see that resistance of piatis to antibiotics reduce our possibility to treat the patient. Other conditions, other diseases induced by piatis, we have seen that tetracyclines are not indicated, so it is not a story. Concerning other bacteria, aureus, Spargensis, and so on, we have seen that the number of influence in terms of bacteria we got was variable. Some bacteria went down, some other went down, and no change in some other studies. So we have no significant data. In terms of resistance, we have no significant data to answer the question, is it clinically relevant? How much is the transmission between P. acnes resistant to clindamycin and the close friend Staph aureus not stick resistance? How much, what is the risk of transmission? Unfortunately, we do not know. And in terms of duration of resistance, this is a very not well-studied point. But you have to remember, as I told you before, resistance may go back. So at the end of the day, we see that the other bacteria, if they needed to be treated, the treatment won't be tetracycline. So, few words about the very interesting aspect of therapy. You know that there is around the world, I don't know if you have it in your country, maybe now, the submicrobial dose of doxycycline. It is a 40 milligram doxycycline, 30 milligram with a quick absorption, and 10 milligram with a late and slow absorption. It has been accepted by our government for the treatment rosacea, as in other countries around the world. Have you? No? No. But I think it's very interesting. As you may say, you told us before that if you use a low dosage of antibiotics, you may get resistance. Yes, you are pretty right. But the studies that are behind this presentation, the launch of these products, suggest that at that dosage, 30 plus 10, there is no induction of resistance. You may see in this study. The results in clinical terms, after 6 months of treatment, 50% of improvement of every kind of active lesions. And in terms of microbiology, you see that there is no change in PIs, such as for other kind of bacteria. So you may imagine what was the comment of microbiologists. They raised on the head the chairs, but and probably they are not fully wrong. Maybe something may happen, but it is not clinically relevant. And the laboratory who did this study is very famous one. So everyone, Jim Radin as the first one, he's very critical and always accepted the data of the study. So in conclusion, we can say that we may influence the microbiome of the body when we use antibiotics, also including the commensal bacteria. But we have nothing to say that increase the occurrence of infectious bacterial diseases. So we can say that with the data available now, we have not stopped the use of antibiotics. But as it has been supported by the Academy in the last Miami meeting in March, some months ago, where the Academy first the attendees raised forward, there are some strategies to use to prevent the occurrence of antibiotic resistance, in particular PIs resistance. So the combination of topical retinoid with an antimicrobial, usually BPO as a topical product, and tetracycline as a systemic treatment, is the first line therapy. Considering the length of treatment of tetracycline as short as possible, and usually the timing is 12 weeks, but you have to check at 6-8 weeks. If you do not get enough results, sufficient results, satisfying results at the time, it is reasonable to change, to switch to another treatment. And the co-prescription of benzoyl peroxide also as cleanser is very helpful in terms of reducing the amount of PIs on the skin. Please do not use antibiotics, both systemic and topical, as monotherapy. And if possible, avoid the concurrent use of oral and systemic and topical antibiotics. And if you do not have an adequate justification, do not switch from one antibiotic to another. And this is a very important point, preventive therapy, because you know that acne patients are scared by acne, but they are depressed when they see that acne after the initial treatment goes back. So please pay attention to preventive therapy, and the use of topical retinoids is the main point in the treatment of maintenance treatment. And if you consider clinically helpful BPO, and avoid, again, maintenance therapy, the antibiotics. So this is a proverb I like much, maybe you know that better than me. And you know that the problem of antibiotic resistance is a very important one. Consider that not in the closed dermatological community, but in the big medical community and patients as first target. And I think we have to go on to work strongly on this point. And as you can see, if you want to go quickly, you may stay alone, but if you want to reach important results, you may work together in a team. So, Chopin, did you try? So, thank you.
Thank you very much, Professor Bettoli, for an excellent presentation. And I think you're going to tell us another presentation about hydrodermatous alopecia.
Yes.
Thank you.
So, this is a very important disease. Maybe it is not so well known, but I'd like to attract your attention on this disease. It is a devastating disease. And as you have seen, I followed the art clinic for 17 years. So in the past I have seen quite a lot of patients, apparently with EWDS superlative. But I have to say that 5 years ago, I was astonished. I have seen a young patient, she was a woman, severely affected by this disease. Her personal life, her social life was absolutely impossible. The smell she had coming from the big falls was so impressive that no one was able to stay close to her. In our waiting room, patients were unable to stay close to her. So that quite impressed me emotionally, personally. So I decided was the case to focus our attention, to use more time to study this disease. So I began to concentrate also on this disease. And I'm very glad to see that in the last years there has been a growing interest in this disease. And you may see in the literature, a lot of doctors, at least in our country, but also in other countries in Europe, also in the Scandinavian area, is a growing interest. That's very good. And I think that after 5 years, very interesting results have been obtained. Just to give you an idea, this is a 11-year-old girl, 108 kilos weight, and she has got sore dermatosis for 2 years. So, what could be the expectation for life for this young patient? What can I expect to have from life, this young girl? I think that with the treatment we have in our hands, we can do a good work on her. Now she is on rifampicin and clindamycin for 10 weeks. We will see the details. So the meaning of this slide is to see that we have an option to cure these patients, but to make the diagnosis as soon as possible. And we have to treat the patient as soon as possible, as strongly as possible. We may stop it. It is a chronic and recurrent inflammatory disease. Please, it is not an infectious disease. Sometimes bacteria may be an overproduction, an overgrowth, an overimposition over the disease. It is basically an inflammatory disease, not an infectious disease. It is caused by a follicular occlusion of the pilosomassus duct, but of a specific pilosomassus duct. We will see exactly which one. Of the terminal hair follicles. And they are located in, particularly in areas of the body where there is a plenty of apocrine glands. The lesions are very painful, are very deep located, and the most frequently located locations are axillae, big folds, ungenital areas, and inguinal areas. Usually, the onset of the disease is after puberty, but sometimes, as we have seen a few slides ago, also before puberty. Females are affected from 2 to 5 times more than males, And there is a positive family history in 1/3, 1/4 of patients. So probably there is a different kind of population. The one affected with the genetic problem and the one affected with like another kind of pathogenesis. The estimation of prevalence is between around 1%, 1% of the population. I'm not fully sure that's a real prevalence. There are studies going on to specify this point. So you see two different names. Italian super and Latin inverse, but just one entity. So what's the matter? The first term is incorrect because apocrine glands are not they do not play a primary role, just a secondary role. Active versa, again, is incorrect because scarce glands are fully unaffected. So, and then what to do? So we have to use the two names because we have no good alternative. We are waiting for that, for the definition that is better, and we have nothing else. And we are speculating on the pathogenesis of the disease. In the past, apocrine gland was considered as a culprit, but now the culprit is the hair follicle, terminal hair follicle occlusion. It's interesting to see that there is a group of diseases where the occlusion of the follicle are the same problem. I mean, acrocolobacter, and also dissecting two lines of the scalp. And so it has been coined the name of follicular occlusional triangle. But then another experience observed that a number of patients affected by HS were also affected. This is also my personal experience. Many of those patients got the so-called vinonidal sinus, or this is cyst on the sacral area. And it's very, very frequent. So the group of kind of diseases included the follicular occlusional diseases went from 3 to 4, so we call the tetra. And exactly the area is this one. And as I told you, there are different kinds of pinocerosis students. This one with very big hair and very small space of gland is the one where HS will develop. To make a difference with this one with big sebaceous gland and very small hair where acne vulgaris is located. So, what is the pathogenesis of the disease? On one hand, we have seen it is an inflammatory disease, and on one hand, it's also a genetic disease. Probably it is an autoinflammatory disease. What does it mean? Autoinflammation is a specific kind of inflammation based on the defect of the inflammasome. Inflammasome is an intracellular system of proteins who has the task to check what's happening to the area. And in order they have to check what happens about bacteria in the area and something about some damage, some cellular damage. So they have a checker. Sometimes, maybe for genetic reasons, the system is broken. And in front of normal events, such as commensal bacteria, and the friction of the big folds, this inflammatory system of the innate immunity works more than expected. So normal stimuli may induce a prolonged and very strong inflammatory reactions. That's why the patients respond so important and so long inflammation. You know that mechanical friction is an inducer of the inflammation on follicular occlusion. So a lot of stuffs goes together to the induction of this sort of disease. And concerning genetics, has been seen And one study has been published very recently in the European Academy of Dermatology journal. 25 families has got a lot of function mutation on the gamma secretase system. It is a transmembrane complex of proteins that may do a lot of things. I summarize saying to you that they are inducer of inflammation. And they also may induce the occlusion in hair follicles in mice. So this is another point very important to study. But another study published on the investigative journal this year from France is very interesting. What is the main concept of the study? It has been seen that probably there are different kinds of diseases inside the same diagnosis. So that typical European HS with a specific clinical aspects, and there are atypical HS. But what I want to stress is that this is a first step. This study is not so precise in defining what kind of families or what types of disease that are inside active versa. But the important point is that it's the first step. I'm sure that in the following years we will be able to understand that there are different kinds of disease with different treatments to focus on specific patients. Many patients affected by HS are smokers, very frequent. But what we do not really know is that if the patient stops smoking, what will happen about the disease. We do not know if the disease will improve. Anyway, it is better to stop smoking. Concerning BMI, many patients are overweight, many patients are obese. So it is important to reduce the BMI of these patients. You know that obese patients have increased frictions on the folds, and a higher temperature favor the growth of bacteria. But as you know, changing habits, it is very challenging, so it's not so sustainable. I don't want to go into details about the problem of staging of the disease, but you know, in general terms, it's important to have parameters in order to define if the treatment is effective or not. So I go straight to the treatment. What can we do for these patients? First of all, we have to consider two different aspects of the disease in terms of clinical aspects: the acute phase and the chronic phase. We have patients with a basic, everyday present inflammation, and sometimes we see the patient experience an acute attack. What does it mean? It means that sometimes single lesions or more than one lesion became big, painful, with the production of purulent material and so on. So we have to keep separated these two aspects. Obviously, with the treatment, the acute phase, our goal is to reduce the number of acute attacks and possibly to zero, and or reduce the intensity of the attack. In our clinic, we tend to treat all the patients independently on the acute phase and the chronic phase with a antiseptic, detergent, and leave-on cream. Concerning the acute phase, at the very beginning, when the patients feel that something may come, our advice is to use a fixed combination of topical antibiotic and topical corticosteroids. Sometimes they are useful to reduce the intensity of the reaction, not always, but sometimes. And if needed, systemic antibiotics, usually penicillin, cephalosporins, macrolides, or quinolones, but for a short course, short period of time, just to face the acute phase. Sometimes systemic corticosteroids are needed, so the intensity of inflammation is really big. And now we move to the chronic phase. We have, obviously, I mean medical treatment. We go then to surgical treatment and to procedures. As a chronic phase, medical treatment, we have systemic antibiotics, we have dapsone, we have cyclosporine, acetylene, zinc, and biotech drugs. Last year, it has been published a therapeutic algorithm by the German group, and this is strongly interested and deeply interested in this disease. And just to give you an idea about what does mean Hardy, Hardy is a system of definition of severity. You may consider mild, moderate, and severe disease. As you can see, for all the three types of disease, you see clindamycin plus rifampicin, both, all of them. Second choice, for moderate cases, if clindamycin and rifampicin are not enough, you may move to local surgery or CO2 laser. I personally would biotech drugs, other Europe and Britain. Again, from Germany, severe cases, clindamycin and rifampicin the first choice, second choice, wide surgery and biotech drugs, and third choice, wide surgery. This is our personal Italian view. As you can see, the decision of the German colleagues is to be strong at the very beginning of the disease. Mild cases, 10 weeks of a combination with rifampicin and clindamycin. It is not so soft treatment, it's quite definite treatment, but they decided to use also for mild cases. Our personal view is a little bit soft, but I have to admit I'm changing idea. Probably it will be used also in mild cases, the combination of rifampicin and clindamycin. Now we use rifampicin and clindamycin as the first treatment just for moderate and severe. But I'm changing idea. We must be strong at the very beginning of the treatment. So, anyway, nowadays we use tetracyclines. In case of response, we move to zinc as a maintenance therapy. Zinc is a little soft as a treatment. Good for maintenance treatment, but not as an anti-inflammatory in a good phase. No response to tetracycline, rifampicin and clindamycin. See moderate and severe cases, rifampicin and clindamycin. If we got no answer from the patients, you see, we move through cyclosporine, dapsone, acetylene, maybe tetracycline, then biotech. Why? That's the difference between Germany and Italy, because our committee, for economical reasons, not allows us to use biotech as early as we would. So we have to go through all the series of treatment. Economy. So, tetracyclines, 6 months of treatment, double dosage. Just to give you an idea, doxycycline, 200 milligrams for 6 months. There is no appropriate references in the literature, but we know that the majority of the colleagues use tetracyclines around the world to treat this disease. Clindamycin and rifampicin, 600 milligrams for each for 10 weeks. It is quite strong treatment, but in our experience, patients tolerate the treatment quite well. We have around 50 patients after treatment and some patients on treatment. We published the study on the European Journal of Dermatological, 23 cases, and we got 85% of improvement in our patients. Just 3 patients had side effects, gastrointestinal side effects, but no one of them stopped the treatment. Dapsone is an interesting option. It is not very helpful in very severe disease, but it is a good option when taken into consideration if you cannot go directly to the biotech drugs. Retinoids, please consider acetylene, non-oral isotretinoin. It doesn't work. No involvement of sebaceous gland, so no oral isotretinoin, but acetylene. It works, it's a good option. Cyclosporine is another interesting option. We use a lot of cyclosporine, and sometimes we see interesting results. We are going to publish around 10 cases at the moment, and I think you have to take into consideration that option. Zinc, gluconate zinc is better tolerated, and I think it's a good one as a maintenance therapy. We tend to use around 200 milligrams for 1 year after getting the reduction of inflammation. So biotech drugs. I'd like just to focus on infliximab. There is a RCT study, and the results are summarized here. You may see that the infliximab, 27% of the patients have got more than 50% improvement, and 60% of the patients have got improvement between 25 to 50%. No comparison with placebo. And concerning adalimumab, this interesting one is useful. The most important study with around 150 patients, RCT study, has demonstrated that the use of adalimumab once a week, not once every other week, has a very interesting result. And doing that way, the patients are allowed for us to be treated once a week. So, I know I'm late, so concerning ustekinumab, there are too few data to take a position. Anakinra, this is a very interesting product. It is an anti-interleukin-1 treatment. You know that interleukin-1 is related to the inflammasome and to the concept of autoinflammatory diseases. And a few cases have been treated in the literature. Prof. Jeremy told me a few days ago that he has treated one patient with interesting results. He was unresponsible to classical biotech drugs, anti-TNF. So, this is an interesting point, and I'd like to involve you as a women of Dermatological Society, because I think it is very important to find a way to collect the patients, to find a uniform way to treat the patients and to follow the patients. You know that these patients tend to be hidden because they have a past experience of no results with treatment, no interest by derms, so they tend to keep secret their disease. So we have to extend the information to GPs, to pediatricians and other colleagues to be able to have the patient referred to us, be able to treat the patient. So we had the first Italian registry, and it was finalized 6 months ago. We collected 245 patients. You have to see that 177 came from our clinic, and right now we have 205 or maybe 6 patients in our database. What is important, obviously, I don't go through all the details, just want to focus your attention on the treatment. The patients who came to us, for 36% of the patients were treated with oral tetracyclines, and 18% of the patients with combination famotidine and amicin. So, I think we have to go on with the registry. We are establishing a second registry, with the online registry. I sent to you the evolution of the registry. The Scandinavian countries have already set up the registry for patients, and they 3 countries, Norway, Sweden, and Denmark, we work together to collect the data of the patients. And I think it is a very important, well done stuff. So, anyway, in conclusion, in terms of therapy, I think that we have to consider that we have in our hands a quite interesting treatment. It is not a conclusive treatment sometimes, but it may be as early as my cases are present in terms of clinical aspects. We may be able to stop the disease. I have experience. So we have to treat the patients as soon as possible and strongly. And this is another option to reduce inflammation, to be able, the surgeons, to treat surgery the patients. Concerning surgery, the most important treatment is why surgery? I mean, why in real terms, if you see here in this study, this one has been considered total excision. It is really not a total excision, because you have to use ultrasonography to understand where really the disease is located, in depth and in the surrounding areas. Then you have to establish how wide is the excision. So usually it is wider than that. It's an important treatment, but at the end of the day, the patient not happy. So a few words on procedures. Lasers, I mean CO2 lasers. In comparison with surgery, I think it is best to use surgery. There is no, but I cannot go into details, but still surgery is the best one. I have no data on PDT and Bettoli to say they are helpful in this disease. So, I'd like to conclude saying that in general terms, we would like to have in life a lot of things, but unfortunately we cannot have all of them. But we have to do the best we can with what has been given to us. And concerning this patient, I think that we have no conclusive treatment in some cases, but we have to do our best to treat the patients with what we have in our hands. And, Shukran. Thank you.
Thank you very much, Dr. Bettoli, for your contribution to some important piece of information. Thank you very much. I think we'll postpone the discussion to the end of the session. Sorry? All right. Any questions?
Please, Professor, the role of metformin in cases like the immunity about the role of metformin and tumor therapy for
the interesting question. I don't have to go through the details because I have time, but some papers trying to metformin is a very important one. I've seen that a lot of patients are obese or overweight, so I think it's very important to measure that sort of medical problem, and I quite frequently use metformin for sort of a good option.
I want to ask you about the trials of non-constant NG
Excuse me?
non-constant NG. Actually, I tried it for several of my patients. They were greatly improved and is highly accepted by the patients.
Excuse me.
Non-constant NG.
Oh, excuse me. And I got it. In terms of anti-inflammatory effect of the lasers, I've seen literature that some good results have been obtained, but I haven't seen, maybe you have seen, comparative studies with medical therapy on one hand and lasers on the other hand. It is very important to compare, and it is also very important to compare the parameters, because you know there are patients with RA1, RA2, RA3, but sometimes you have in the depth the presence of scars and sinus stripe very deep. So when you make this comparison, if you do not have an exact idea with ultrasonography, for instance, to see what really happens in the depth, it's very difficult to compare data. And in my knowledge, it is too early to advise the patient that sort of thing.
Thank you very much, Mr. Chairman, but you gave actually the chance for the other chairman, Professor Habib, to ask. I was going to ask the same question, so you burned my question. You should give it to the ground before. Anyway, metformin is not acting because it is usually acting to obesity, but it has something to do with certain... I think, can you hear me now?
Yeah.
Okay. I think metformin is not working because it's only acting for obesity, but we can give it to any kind of patient who is suffering from mild to moderate. and it saves a lot of complication of long courses of antibiotics, because as I saw here, you give people clindamycin, I think, and the rifampicin for 10 weeks. How many side effects of these two drugs you encountered in your studies?
First point, metformin is not affecting on the disease. It is affecting on the obesity that indirectly affected on the disease.
No, it has something to do with certain lysosomal enzymes. It's working in this way. This has been published recently twice, and actually is a leading article in the European Academy, the Journal of European Academy. But of course, there is a lot of discussion about this. I do agree. It's usually preferred to give it to the obese people, but actually it was suggested by some other persons. Actually, they mentioned that it can work for certain cases, even though they are not obese. But I'm asking now about what is the complication, what the side effects you get while giving rifampicin for 10 weeks with clindamycin.
In our experience, we had 3 patients, as you have seen in the paper I published. They had some problems with the GI tract, but no one of them had to stop the treatment. And you may consider that a quite strong combination between the clindamycin and rifampicin, but you know that when you have to solve a problem, you put on the balance the severity of the problem and the possible risk of the treatment you use to solve the problem. And in this case, the balance is strongly for the combination of rifampicin and clindamycin.
Please, some more details about resorcinol. We used to use it in very low dose. It's first time to hear 15%. What is the vehicle and what's its role? Thank you.
What's the vehicle?
The vehicle used, yeah. Well, 15% in what? In cream or solution or resorcinol?
I have not a wide experience on resorcinol because I tend to use topical clindamycin. And usually it is used at 15%. But we have no personal experience on that. No, it's not my personal experience. It was a study of Dr. Berg and Dr. Jen from Denmark.
Yes, sir. I have a question. Yes, yes. Regarding isotretinoin with hydrogenate subretinal, what is your experience to be used as a monotherapy or a combined therapy or adjuvant therapy? This is a basic question.
Could you please repeat? I'm sorry.
Isotretinoin.
Yeah.
Yes, systemic isotretinoin to be used with hydrogenate subretinal as off-label medication. As off-label medication.
As I got.
This is the question. What I want to ask to answer Dr. Tag Ambar, we can use resorcinol very support to be used in alcohol acetone mixture. This is the only way it could be used, dissolved with. Dissolve it. We can dissolve the resorcinol with alcohol acetone mixture by 1 to 1 or 5 milliliters to 5 milliliters. This is a way. Could be available to use the resorcinol in the philosophy and use it. Yes. But I need to answer the question I had asked of your medication of isotretinoin with hydrogenate subretinal.
If I got the question fully, I do not treat patients affected just with either HS, with oral isotretinoin. I treated patients with HS, but at the same time they had acne conjunctivitis. So I had good results for acne conjunctivitis, but no results for HS. If I got the answer, I'm sorry. Is it, what was it for that?
Thank you very much. We regard this as the last question. Thank you very much, Professor. And it's been nice having you. Thank you.